Hello everyone, it's Dr. Rida Khan and you are watching Medico's Guide. In this video, we are going to be talking about neurological level of injury, that is NLI. And here in this video, we are going to be talking about the importance of determining this neurological level of injury and what tool is used to assess this and what are the important rules that should be kept in mind whenever we are determining neurological level of injury. And then finally, we will talk about how to practically find the level of injury, right? So now first, let's talk about the importance of determining this neurological level of injury. So as you know that this can tell us about the extent and impact of the spinal cord injuries. So in this way, whenever we come to know about the spinal cord injury level of the patient, so this can guide us in the treatment of the patient, in the rehabilitation of the patient, as well as it tells us about the prognosis of the patient, that how the patient is going to be recovered, how much time would be required by him, and as well as the long-term outcomes of the patients, as well as this tells us about the functional impairments. It means the activities that the patient cannot perform. So on the basis of all of these informations, we can guide a proper treatment, we can guide a proper design for the patient, a treatment protocol for the patient, so that we can improve the quality of life of such patients, right? So now we are done with the importance of the neurological level of injury. Now let us talk about what tool is used and what are the basic rules we should keep in mind, right? So the one important tool that is used to assess this neurological level of injury is the AGR tool. Now what is this AGR? So AGR is basically, A stands for American, S is for the spinal, I is for injury, and this A is for association. So basically this is American Spinal Injury Association, and it classifies the spinal cord injuries based on the standardized motor and sensory assessment. So it means that basically we can use this tool for the two main purposes. And these two purposes are that we can use it to determine the neurological level of injury on the basis of two sensory. When we are finding out the AGR scoring, we have to find out two sensory levels, two motor levels, and then it gives us the overall neurological level of injury of the patient, right? So this is the first important purpose of it. And the second important purpose of it is that this AGR impairment score is used to determine the extent of the injury of spinal cord, right? So whether the patient has complete spinal cord injury or the patient has incomplete spinal cord injury, we can also determine this from the AGR impairment score. So basically for this purpose we have a different scoring, and for this purpose we have a different scoring, but the scale is same, that is the AGR scale scoring, right? Now for the complete and incomplete, basically we the AGR categorizes it as A, B, C, D and E. So basically they are different grades, right? So here in the A grade, it means that the person has complete spinal cord injury, while the BCD, they tell you that the patient has incomplete spinal cord injury, and the E1 is completely normal. We will talk about this purpose of the AGR scoring in our next video, or maybe in the later part of this video, and it all depends upon the time. So if you got sufficient time, so we will also discuss about this function in this video. But primary purpose would be to determine the neurological level of injury and to basically master this whole scale, right? Okay, so now as we have talked about the tool, now let's talk about the basic rules that we should keep in mind whenever we are determining the sensory levels, the motor levels, and then the overall neurological level of the patient. So what are those primary rules? Okay guys, so now first let us talk about the motor level, or you can also call it a myotome. Right, so now first here we should keep in mind the following things. So in the motor, or while assessing the motor levels, we should know that first of all it is determined for left and right both sides. Then the value should be most caudal highest value, right? It should be most caudal. Caudal means inferior, So the value that we are going to, so the myotomes that we are going to find out in the last, we have to pick out the most inferior value and the value that is highest. We will talk about it and we will find it out practically, so you will get an idea more when we will find it out. So highest value or the highest grade, you can say. Now what else is that? And as you know that the motor level, it starts from C5 to T1 for the upper limb, and then from L2 to S1 for the lower limb. So here it means that we don't consider any thoracic level from T2 to T12. They are not included here. Okay, so what does it mean? That shouldn't we consider this level? No, but we are going to consider this thoracic level via the sensory level. So it means that we are just going to talk about the myotomes of the upper extremity and the lower extremity. Then when we are assessing these myotomes, we have to remember the 10 key muscles. So basically this is core. It incorporates 10 key muscles. So 5 muscles are of the upper extremities, right, and the 5 muscles are of the lower extremities. So this is how it is divided. Now let's talk about what are those 5 muscles. So basically, as you know that in the C5, it is responsible for elbow flexion. So here we have the muscles like the biceps brachialis. Then C6 is responsible for wrist extension. So here we have the muscle that is, okay, so it is responsible for wrist extension. So here we have the muscle that is extensor carpi radialis longus. Now in the C7, that is responsible for elbow extension. So here we have the triceps, elbow extension. Okay, now the C8. The C8 is responsible for the finger flexion, and basically here we have a muscle that is finger flexor to the middle finger, that is flexor digitorum profundus. So first of all, finger flexor, okay, finger flexors. Now the T1. So the T1 is supplying a smaller finger abductors. So here we are going to assess finger abductors. So here we are going to assess what? The abductor digiti minimi. Now in the L2, that is responsible for hip flexion, we are going to check the myotome of the iliopsoas muscle. Then the L3 is for the knee extension. So we are going to look for the power of the quads muscles. Then the L4, that is responsible for ankle dorsiflexion. So here we are going to check or assess the myotome of the tibialis anterior. Then the L5 is supplying a toe extensors. So for the long toe extensors, we have extensor hallucis longus. So it's of a bigger toe, right? Then we have S1, and that is responsible for the ankle plantar flexion. So here we are going to check the myotome of the gastrocnemius and soleus. Alright guys, now so this was about the 10 key muscles, and you should remember the names of them because it is very important. So whenever you are assessing the myotome of the patient, for assessing or for determining the neurological level of injury, you should know that what muscles you have to find the score of. And as well as there is important thing that whenever we are finding this the myotomes for the ASIA scoring, so the MMT is going to be different here, right? So MMT that is used to find out the ASIA scoring, it is different. And now we have to keep in mind the 10 rules that we have to incorporate whenever we are finding the MMT for the ASIA scoring. So it is different from the standard MMT that we use normally. Okay, now what are the 10 rules that we should keep in mind? So first is the normal thing that we use in the standard MMT, and that is that whenever we are assessing the patient's myotome, we have to start with the grade 3/5. That is normal active range of motion, right? Then the second rule is that whenever we are downgrading or MMT, whenever we are saying that the patient has below 3 by 5 level, it means whether the patient may have 0, 1 or 2. So these are the downgrading, right? So this is basically downgrading. So whenever you are downgrading the patient, you have to make sure that it is not because of pain, right? It shouldn't be because of pain, but it should be due to any neurological deficit. So if the patient is restricting any movement, if he is not able to perform any movement, it should be because of the neurological deficit, and it shouldn't be because of any pain. The third rule is that we are going to mention not testable if the patient has serious contracture, if he has severe pain or severe spasticity, that it makes it impossible for us to assess the MMT of the patient. So then in that case we are going to label it as not testable. Fourth rule is that in the upper extremity and in the lower extremity, whenever we are finding grade 1 by 5, what we should keep in mind that whenever in the upper extremity we are finding this grade 1 by 5, we should keep the extremity in gravity eliminated position. It means we have to eliminate the gravity, we have to provide the plane to the patient so that he can perform the movement easily, right? While in the grade 1 by 5 in the lower extremity, we are going to assess the MMT in the anti-gravity position, right? So this is the common difference and important difference that you should remember. So in the anti-gravity position, we are going to find out the 1 by 5 grade of the lower extremity, but except, what is the exception? So we cannot find the plantar flexion in the anti-gravity position, right? We cannot make the patient to become prone in order to perform the plantar flexion in the anti-gravity position. So we have to do it like we do it in standard MMT. Now the fifth rule is that whenever we are assessing 4 by 5 level or the 4 by 5 grade of upper extremity or lower extremity, we have to assess it in the anti-gravity position. And as we already talked about, that we have to assess the S1 and the T1, these two levels in the gravity eliminated position like we do normally, because these cannot be assessed in the anti-gravity position. So basically the T1 is for the finger abductor, so this movement, right? And the S1 was for the plantar flexor or the plantar flexion. So as we already discussed, that this cannot be performed in the anti-gravity position in the supine position. Okay, now the sixth rule. So the sixth rule is that we shouldn't use any half marks, we shouldn't use any positive or negative signs. It means that we should just normally mention it as in the whole numbers. So if it is 0, we have to mention it just 0. If it is 1, we have to mention it just 1, not 1.5 or plus 1 or the minus 1. No, all of these are not acceptable, right? Now the seventh rule is that whenever we are assessing grade 2 by 5, 3 by 5, 4 by 5, 5 by 5, in all of these grades, the patient should be able to perform the movement throughout the range, right? Patient should be performing these grades in throughout the range. And in the 4 by 5 and in the 5 by 5, these movements are performed against gravity, as it is true for the standard MMT, right? Now the eighth rule is that the patient shouldn't be performing any trick movements while we are assessing the MMT, right? So trick movements are basically, you can say, the alternative movements. If the patient is not able to move, for example, if the patient is not able to flex the fingers, let's take this example. So we have to say the patient that he flexes the wrist so that he can perform this movement really well, right? And he must not be doing any other type of movements, or you can say the substitution movements, right? Now the ninth rule is that we can modify the testing positions if there is loss of extensibility, right? We can modify the testing position just as I've given you the example, right? That if the patient is unable to perform the the finger flexion, so maybe there is a loss of extensibility in the finger flexors, so, or which is you can say in the simple word means that the wrist flexors are the finger flexors are tight. So because of that, he cannot perform the finger flexion properly. So we have to tell that, please flex your wrist so that you can perform this movement, or extend your wrist so that you can perform this movement very well. So this would be an appropriate example of it. Because in this way, when the person would perform the wrist extension, he would be his finger flexors would be loosened, and he could do this movement very easily. And please correct this example in the previous one as well, because I don't know, it went wrong. So my apologies for that. Okay, our 10 rules are completed, as this one was also a separate point. Okay, so we can include it in the 10th. So here, these are the 10 rules that you should keep in mind whenever you are assessing the MMT of the patients for determining the neurological level in ASIA scoring. Okay, now let's talk about the sensory part or the dermatomal part. So here, as it was true in the motor level, so you have to determine the sensory levels of both the right and the left sides. And then here in the sensory, we have 28 key points. In the myotome, we were remembering this thing. It was important to remember this thing, that there were 10 key muscles. Now here in the sensory part, we have 28 key points. It means the 28 points where we have to find the dermatomes, right? And here in these 28 key points, here we can find the dermatomes by the pinprick sensations, which is a very common thing and it is normally used. And you can also find the light touch. And as in the ASIA scoring, you have both of them. You have to determine both of them. So you have to use both of these sensations. And then the third important rule is that you have to pick out the most caudal highest value, as it was true in the motor level. So this is very important thing. Later on I will tell you that what is the importance of it. So here most caudal highest value, and here as well we were picking out the most caudal highest value. Okay, so keep this thing in mind, because this is gonna help you out when we are finding the overall neurological level of injury, so that you might not get wrong. So you have to remember this thing. Now let us talk about the grades of the sensory part. So here in the grading, we graded as 0, 1, 2 and not testable. So as I've told you, not testable in cases of where there is severe contracture, severe pain or severe spasticity. Now these are the main 3 levels. So 0, 1, 2. So 0 is when the patient does not feel anything whenever we are giving the stimulus to the patient. So if the patient cannot distinguish between any sensation, we are going to label it as 0. And the 1 is when the patient's sensation are different from that on the face, from that what he could feel on the face, right? And as you already know that the benchmark, what is the benchmark? So benchmark is basically the sensation that we consider to be most accurate. So the benchmark in our body is our forehead. So we consider the forehead sensation to be most accurate, and then we compare it with the other parts of the body. So when the patient is going to feel it different from that what he could feel or sense on his face, we are going to label it as 1. While if he could feel the same as that he could feel on the face, so we are going to label it as the grade 2. It means that his sensations are all right. He is fine, right? And now the last thing that we should keep in mind is that about the overall neurological level of injury. So this level that we are going to pick out at the last, when we have determined already about the sensory levels, 2 sensory, 2 motor levels, now we have to pick out the most cephalic level in order to determine the overall neurological level of injury. So basically when we have determined both of these levels, we have to arrange them, right? I will show you later on that we have to arrange those all levels that we have got, and then among them we have to pick out the most cephalic level, right? So let me do it this way so that you can see it. Most cephalic level. Alright, so this one is also very important. Now let us go on to finding out practically that how we can determine the neurological level of injury. Okay guys, now let's get started. So first of all, we have two sections in the ASIA scoring, and these are myotomes and dermatomes. Let's label them. So we have myotomes, and here we are going to determine the dermatomes, right? So now first of all, you should keep in mind certain things whenever you're finding the myotomes, is that you have, as I've already told you, there are 10 muscles total on the right side, five of the upper extremity, five of the lower extremity. So 10 muscles, and as you know that the highest grade is 5. All right, so 5 into 10 makes 50. So it means that on the right side you are going to have 50 total scoring, and and similarly on the left side. So on the left side as well, we have 10 muscles, and the 5 grade is most highest grade in MMT. So 10 into 5 makes 50. So 50 is scoring on this. So it means that total scoring of the myotome is going to be 100, right? Now for the dermatome, as you know that on the right side we have 28, and as you know that we have 2 as the highest grade. So now 2 into 28 makes 56. And similarly for the left side, there is 28 into 2 and it makes 56 again. So 56 into 56, 56 plus 56. So both of them when summed together, they form 112, right? So this is the total scoring. Now let us assume the values of the myotome and the dermatome, and then we will figure out, or we will then pick out the most what value? Most caudal value. So I'm just assuming these, so you can just fast forward them, right? So C5, C6, C7, T1, L2, L3, L4, L5, S1. So let's just assume the values here. We have 2 by 5, 3 by 5, 4 by 5. For example, let's consider it to be 2 by 5 and 2 by 5 here as well. You know, on the patients, you don't have to consider it, okay? You have to measure it. You won't do like this. I'm just assuming it because we don't have a practical, we don't have a real patient in front of us. So I'm just considering it to be like this. Okay, I think that I'm done here. All right, now guys, I'm done with the myotomes. So what is the most highest value? You can see on the right side. So here we have this as 5 by 5. So now let's label it as, let's select this level, and I think I have just put the same levels on both sides. Yes, the patient can have the 5 by 5 on the same level, but to make it a bit harder so that you may not, because that can also be the case. Maybe the patient would present 5 by 5 here on this level. So let's consider this as 5 by 5, okay? So that you may have a new example. Otherwise it would be easier for me as well as for you to do this example, right? So as we have 5 by 5 here, so it means that on the left side we are going to consider this as our highest level. Now write it down. So what you got in the MMT, you got that on the right side you have which level? L5 as your highest most cephalic level, most caudal level. And what is the grade of it? It's 5 by 5. Now on the left side you have L4, and what is the value of it? You also have to mention the grade, okay, or the value, what you can say. So here we have this, what we got. Now let's talk about the dermatome. Let's assume the values of the dermatome. So as you know, we have 28. It means from C2 to S5 all the levels, okay? So I'm just gonna mention few of above levels and a few of the below levels, right? So maybe it's like this here from the above levels, and this is going to be of the right side, and let's consider the left side values to be on this side. Now okay, L5, S1, then we have S2, S3, S4, S5. Okay, now let's assume the values. So maybe the patient had 2 by 2 here, 2 by 2 here, 1 1 0 1 1 0 2 2, or it can be any values. Okay, so now down here, now we got here 1 1, maybe 2 here as well, 0 2 1 1 1 0 1 0 0 1. Okay, so these are all the values. So here you can see that most highest and you can say the caudal value is 2 here, and this is of what? Okay, we are basically relating to this. Okay, so this is of the L3. Now on the left side you have the highest most caudal value, which is 2 here, so it is relating with the L5. So now you have these two levels. Now let's write it down. So in the dermatome, what you got is, on the right side you have L3 as your highest value, and the grade is 2 by 2. Now on the left side you have L5 as your highest and your most caudal value. Okay, so this is what you have got. Now let's merge them in order to find out the overall neurological level of injury. So now we have to basically arrange these levels in the, for example, what comes up and then what comes down. So in this way, in the ascending order. So here we have L5, L4, sorry, L3, L4, L5, L5. So here we are done. This was L3, this is L4, this is L5 and L5. And you also have to mention the grades, okay? So it's 2 by 2, it's 5 by 5. Well, it's not that important to mention the grades, but you can mention them. Okay, so now for determining the overall neurological level, you have to pick out what? Most cephalic level. So here you have the most cephalic level. So it means that L3 is your answer. Okay, so you can write it down that the L3 is your overall neurological level of injury. So this is your correct answer. Okay guys, so we have discussed about the one aspect or the one importance of the ASIA scoring. Now let's talk about the ASIA impairment scale in a quick way. So basically, as I've already told you, that these are used to categorize the spinal cord injury into two, and these are the complete or incomplete spinal cord injuries, right? So the first grade is for the complete spinal cord injury, and here the patient wouldn't have any sensory nor any motor, and there is no sacral sparing, right? Now the BCD, as I've already told you, that these represent incomplete spinal cord injury. So here first in the B grade, the patient would have normal sensory, but there is no motor. In the C, in the C we have normal sensory as well, but in the 50% of the muscles, these are going to have less than 3 grade. Alright, it means that half of the muscles that are below the level of injury are going to have less than 3 grade. Now in the D grade, the sensory is intact, while in the 50% of the muscles are having above 3 grade, right? So this is about the D grade. Now the E shows completely normal patient in which there is intact sensory and intact motor. So as you have already guessed that this ASIA impairment scale was made on the basis of sensory and motor in the S4 and S5 levels only. Okay guys, so that's all from my side. I hope that everything is clear to you now, and if you have any question you can comment me down below, and you can also give me some ideas that what to make videos on. So okay, we will meet in the next video. Thanks for watching. And also, if you have enjoyed this video, please don't forget to like this video as well as subscribe to my channel if you haven't already yet. And bye bye.